Good afternoon and welcome to the National Prevention Week 2019 webinar series. Thank you for joining us. Today's webinar is being recorded, and I will now turn the webinar over to our moderator, David Lamont Wilson from SAMHSA. Please go ahead, David.
Thank you, and welcome everyone. I am David Lamont Wilson. I'm a public health analyst at the Substance Abuse and Mental Health Services Administration's Center for Substance Abuse Prevention, or CSAP. And I also have the privilege of being the coordinator for SAMHSA's National Prevention Week initiative. I will be your moderator for today's webinar. And so I'm going to start by saying research suggests that substance misuse, especially opioid misuse, is a growing public health issue within the nation's older adult population. And the rate of opioid misuse among older adults nearly doubled between 2002 and 2014, according to SAMHSA's National Survey on Drug Use and Health. Now, while older adulthood is often not typically associated with increased substance misuse, health challenges associated with aging, such as arthritic-related pain or back pain, are leading more older adults ages 50 and older to seek prescriptions for opioid medications. Understanding what questions patients, their caregivers, and their healthcare providers should ask about opioids is critical to improving health literacy regarding the substances, and it is an effective prevention strategy for addressing the opioid crisis among older adults. Now, today's panel of presenters will help us understand the effective prevention strategies, the approaches, and resources that can advance understanding and create dialogue between older patients and their healthcare providers about opioid use. So before we begin, I would like to just make a couple of housekeeping announcements. Please use the chat pod to send us your thoughts and questions throughout each speaker's presentation. There will be a question and answer period following all of the speaker presentations, and I will pose your questions to the panel at that time. 2, this webinar is being recorded, as you guys know, and it will be available on SAMHSA's YouTube page. So if you have colleagues or coalition partners or other prevention professionals who weren't able to join us today, they can access it on demand when it is available, and that usually happens in about 2 or 3 days after the call is over. Now lastly, as we will make the slide presentation available after the webinar, so you will have all of the information, all of the resources, and the tape discussion from today's webinar. And you can share that data, the resources, and the strategies that we've discussed with your colleagues and partners. Now, I wouldn't be a good coordinator of National Prevention Week if I didn't take just a little bit of time to talk about National Prevention Week. So this webinar series is one of the many resources, activities, and events available to you through National Prevention Week, and I'd like to just take a few minutes to highlight a few others for you to explore following this webinar. Now, each year, SAMHSA selects a theme for National Prevention Week, and this year's theme is Inspiring Action, Changing Lives. And this theme reminds us that we can all inspire positive change throughout the year, every day and everywhere, whether we make healthy choices for ourselves or inspire others to do so. Those small actions we take can change lives for the better. Now, this year, each day during NPW in May, we focus on different pressing health themes, and we encourage you and your communities to discuss the various aspects of prevention. Now, communities around the country host health fairs, trainings. I've seen mural paintings, town hall meetings, Twitter chats, and other NPW activities and events to contribute to this growing conversation that we must have around prevention. This year, we have an exciting challenge going around NPW that we like to call the Prevention Champion Challenge. Now, how do we define what a prevention champion is? A prevention champion is a person, activity, program, an organization that inspires others to take prevention actions every day that change lives. Now, it can be a colleague at your organization who is leading the charge on an innovative substance abuse prevention program, or it might be the Silver Sneakers program at your local YMCA that is helping seniors get into shape. Whoever or whatever it is that is inspiring people to take prevention actions that change lives, we definitely want to hear about it. So you can take part in the challenge by sharing a photo or a video of your champion and adding one word, just one word that you feel best describes them. Now, participating in the challenge is easy, and it also is a lot of fun. There is no need to stress over finding the perfect picture. You can post any photo or any video that expresses how you feel about your champion. And if you want to share multiple words about your prevention champion, that's okay too. So share your post about your champion on social media using the hashtags Prevention Champion and NPW 2019. Now, people are already taking part in the challenge, and as you'll see here, I Got This Chicago is inspired by the teens and parents in their city who choose to talk about underage drinking and living healthy lifestyles free of alcohol. Now, Shay has chosen Rise Consultants as her prevention champion because she is innovative. So now it's your turn. And we encourage you to take the challenge and get your colleagues, your friends, and family involved by tagging them on social media and promoting them to take the challenge too. It is never too early to look ahead, and we're already thinking about NPW 2020. So next year, our goal is to only use real people of organizations and people across the country that are doing great prevention work, and all of our NPW materials, especially our planning guide and resource calendar. We want to showcase the prevention efforts taking place all around the country, featuring your photographs. So be sure to capture pictures of your activities during MPW this week that you can share with us. And they might just be included in our planning guide and resource calendar and other materials. And as a reminder, you can also still order print copies or download a PDF of this year's planning guide and resource calendar in the SAMHSA store. So, in addition to taking part in the Prevention Challenge, you can also get involved in visiting samhsa.gov/Prevention Week for the latest prevention resources, the planning prevention activities, and events in your community, and sharing information on social media using the hashtag NPW 2019. Now, I hope that you guys are as excited as I am about MPW this year, because we do know that even though we celebrate it during the week, prevention happens every day. Prevention should happen every day, and everyone has a role to play in making our communities healthier. So, with that being said, I want to kick off our presentation today with my colleague and my esteemed colleague, Jennifer Solomon. Now, Jennifer is a public health analyst for SAMHSA Center for Substance Abuse Prevention. She serves as the program lead for developing substance abuse prevention programs for older adults, such as the Get Connected Toolkit and a webinar series on substance use, mental health, and older adults. She is the federal champion for SAMHSA's Treatment Improvement Protocol number 26, which is substance abuse among older adults. She has a master's degree in applied sociology with an emphasis on aging from the University of Maryland, as well as a graduate certificate in gerontology. So without any further ado, please welcome my esteemed colleague, Ms. Jennifer Solomon.
Thank you, David. Substance use and misuse in older adults. Prevalence of substance use misuse in older adults. More than 80% of older adults use at least one prescription on a daily basis, with 50% taking 5 or more medications and supplements daily. Nearly 16.2 million older adults over the age of 65 drank in the past month, with 3.4 million reporting binge use, alcohol use, and 772,000 reporting heavy alcohol use. SAMHSA's Tip 26, Substance Use Among Older Adults, estimates that a combination of alcohol and medication misuse affects up to 19% of older Americans. The opioid crisis in older adults. How has the opioid crisis affected older adults? Rates of opioid analgesic use is higher among older adults, at 8.1% for ages 40 to 59 and 7.9% for those 60 and over. According to CDC's Morbidity and Mortality Weekly Report, in 2016, more than 44,000 Americans died of opioid overdose deaths, of which more than 7,000 were age 55 and older. And the National Household Survey on Drug Use and Health data indicates that opioid misuse increased among older adults 50 and over from 1.1% in 2002 to 2% in 2014. And by 2020, it is estimated to increase by 3.1%, totaling 5.7 million people. Emergency department visits related to medication use and misuse. 1/5 of emergency department visits involving prescription medication use among older adults were made by persons 70 and older. Medications involved in emergency department visits made by older adults found that 43.5% of pain relievers and 31.8% of medications for anxiety and insomnia and 8.6% for antidepressants. What happened after the 8 emergency department visit? It was found that 52.3% were treated and released, but 37.5% were admitted to the hospital, and that's a pretty high rate for this population. SAMHSA has a lot of activities focused on older adults. We have the Older Adults Evidence-Based Mental Health Practices Panel that we held in June of 2017. The Older Adults with Serious Mental Illness and Behavioral Health Workforce met in May of 2018, and Older Adult Mental Health Awareness Day was held in May 2018 and will be held this year at the Humphrey Building down in Washington, D.C. on May 20th, 2019. We also have the Aging and Disability Resource Center that we have worked with from Administration for Community Living, and when they have worked with older adults with serious mental illness and the expert panel on August 2018. And we also held the Older Adult Peer Services panel on 2018. And National Prevention Week has now focused older adults. This is the first time, and we look forward to future years of including programs on older adult populations, which we are really excited to include. And we also have the treatment improvement protocol that we are doing a complete rewrite in progress, and that should be out in late 2019. SAMHSA's role with the Administration for Community Living has been a partner with us, I think, for the last 20 years. We want to develop stronger ties with ACL in order to provide training and technical assistance to improve service delivery, support family caregivers as well as their older adults, improve the workforce, and identify evidence-based practices, which is extremely important. And another one, we want to make sure that the public gets the information that they need. Get Connected, Linking Older Adults with Resources on Medication, Alcohol, and Mental Health was developed originally in 2003. We are on our 5th edition of this toolkit. The Get Connected Toolkit helps communities build health promotion programs, offer prevention messages and education, and provide screening and referral for mental health problems and misuse of alcohol and medication. You can find it on the SAMHSA website, and you can find the It Can Happen to Anyone and Anyone Alcohol and Medication Among Older Adults video on our YouTube site. The Get Connected Toolkit goals are to educate older adults, link older adults to resources, help providers and staff understand substance use and misuse and mental health issues, and increase staff confidence and competence. So this is a basic tool that really provides the information an organization or an aging service provider would need to get started to start looking at health promotion programs in older adults around medication misuse and use, alcohol, and anxiety and depression. This kit does not go into serious mental illness. The Get Connected Toolkit Goals continues, helps organizations understand and assess how ready they are to deliver substance use prevention programs. There's a substance use matrix included in the kit that organizations can fill out. We also encourage peer support, and we also provide additional training tools and resources within the kit. The kit book, it's a book, and you can also download it online at the SAMHSA store, has everything that you will need if you choose to use it as a tool or if a community wants to develop a whole program around the toolkit. There are session topics. We call them Get Connected session topics. Session 1 talks about it can happen to anyone, coping with life transitions. We know older adults go through many life transitions, and this helps talk about how life transitions can affect an older adult's alcohol or medication use, also how it impacts anxiety and depression in this population. Session 2 talks about using your medications wisely. We know it's very important that older adults know and understand what they take and how to take it. And Session 3 is keeping a healthy outlook in life. We want older adults to stay positive, and this talks about goes more into life transitions and how it may affect your mental health outlook. Who will benefit from using the Get Connected Toolkit? We know that senior centers, adult day health services, nutrition programs, state and local agencies, the Administration for Community Living's area agencies on aging have used the kit, health and social service providers, faith-based organizations, and even nursing homes have used the toolkit. Now I wanted to talk about resources that you can use as a companion to the Get Connected Toolkit. The National Institutes of Health resource provides questions older adults can ask their doctors about the medications they are taking. These are simple questions, and this is just a sample of the questions, and I chose a few that would really fit well with the kit. What is the name of the medicine and why am I taking it? What medical condition does this medicine treat? How many times a day should I take the medicine and at what times? If the bottle says take 4 times a day, does that mean 4 times in 24 hours or 4 times during the daytime? The last 2 bullets are very important because these are directions that come on a lot of medications that people find very confusing. If you do, always go to your pharmacist or call your doctor to make sure you understand what you're taking and how to take it. And that goes across the lifespan. These questions are really good, not just for older adults, but for people of all ages. This is a state example of prescribing guidelines on opioids. We found this one from Pennsylvania. These guidelines are intended to help healthcare providers improve patient outcomes when providing opioid treatment, including potential adverse outcomes associated with the use of opioids to treat pain. So Pennsylvania has gone in and has made a complete guide on how to prescribe and what it means to prescribe opioids to an older adult, as well as how to treat pain. So additional actions communities can take when using the Get Connected Toolkit. One would be also communities can start utilizing NPW resources. They have been a lot for youth, but now that we're working across the lifespan, I would take advantage of all of those resources the National Prevention Week uses in a community. Participate in National Drug Take-Back Days. The DEA really works hard to work across the country to have medication take-back days. It's really important to educate community members who work with older adults to understand the importance of making sure that they dispose of medications that are not needed and they are not using. Holding on to them for future use if they're really not going to use them can be dangerous because they could take multiple medications of the same medication at the same time. And I know Kathy Cameron will be going into that later in the presentation. Share SAMHSA resources with your community. Educate members of your community about how to talk to their doctors and other prescribers about medication. Health literacy to me is one of the most important pieces, and educating older adults about what they take and even how much to take around alcohol, what drinking limits are very important as well. And these are some additional SAMHSA resources that focus on mental health, promoting mental health and preventing suicide, a toolkit for senior living communities, and promoting emotional health and preventing suicide. These will also go nicely with the Get Connected toolkit. Here are some pain medication fact sheets, and SAMHSA has an opioid overdose prevention toolkit. Here are some more pain medication resources, and here's one that talks about how to, what am I taking, how am I taking it, and a person can write down what they're taking. This would also go very nicely with the Get Connected toolkit. Here are the additional SAMHSA resources: the treatment locator, the suicide hotline, and the national helpline. And if you have any questions, here's a slide with my contact information. You can reach out to me at any time. Thank you very much.
Thank you, Jennifer, for sharing all of that recent data on opioid misuse among older adults, and also touting all of our useful SAMHSA resources as well. Now, our next presenter is Kathleen Cameron from the National Council on Aging. Now, Kathleen has more than 25 years of experience in the healthcare field as a pharmacist, as a researcher, and a program director focusing on falls prevention, geriatric, mental health, long-term services and supports, and caregiving. She was previously with JBS International as the director of a SAMHSA-funded technical assistance center aimed at educating the aging network, mental health providers, and policymakers about behavioral health conditions among older adults. She also has held a position at the American Society of Consultant Pharmacists Foundation. So with that, we all welcome Kathleen.
Thank you so much, David, and good afternoon, everyone. It's great to be here as part of this, this webinar on improving opioid misuse prevention literacy. I'm with the National Council on Aging, as David mentioned, and for those of you who are unfamiliar with NCOA, we believe every person deserves to age with their best possible health and economic security. And we empower individuals with trusted, proven solutions to improve their daily lives. That includes tools like our benefits checkup, evidence-based health promotion, disease prevention programs, and our Aging Mastery program. I direct NCOA's Center for Healthy Aging, and we are funded through the Administration for Community Living. We lead 2 national resource centers, and we provide technical assistance and support to state and local community-based organizations to implement and sustain evidence-based health promotion and disease prevention programs. And I'll talk a bit about some of these programs later in my presentation, some of those that can help improve health literacy and help address the opioid misuse and abuse problems among older adults. We have a lot of resources on our website, so I really welcome you to take a look at our clearinghouse of best practices, information on chronic disease management, falls prevention, and a range of health promotion disease prevention programs. So to start, I thought it would be important to begin with some definitions. So this webinar is focused on health literacy. And health literacy is the capacity of individuals to obtain, process, and understand basic health information and services needed to make appropriate health decisions and take appropriate action related to their health. In general, health literacy is really important because it affects a person's ability to navigate the healthcare system, and as we all know, it's very complicated. Sharing personal information, such as health history, with providers that individuals are seeing. It's also important in engaging in self-care, and that includes chronic disease management. But health literacy is also important for individuals so they can understand, health information provided by their doctors, their pharmacists, and other healthcare professionals. And there are a number of factors that impact an individual and a system's influence on health literacy, and some of those are mentioned here, including communication skills, patient and professional knowledge, culture, and demands on the healthcare system. Um, Opioids. This webinar is focusing on opioids, and I wanted to make sure everyone understood what opioids actually are. Opioids are a type of drug. They come from the opium poppy, the plant, so they're a natural substance, or they are produced synthetically. So a drug like fentanyl is a synthetically produced opioid. Opioids can be illegal, like heroin, or they can be provided through prescriptions, like all of those that are listed here on this slide. Things like codeine, oxycodone that's found in Percodan or Percocet, hydrocodone, which is found in Vicodin or Lortab. Opioids actually, act in the same way in the brain. They attach to specific proteins in our body called opioid receptors, which are found in the brain, spinal cord, in our GI tract, and other parts of our body. And when opioids attach to opioid receptors, they stop the body from sending pain signals to the brain. In addition, opioids also cause euphoria or a feeling of ecstasy, and users generally report feeling warmness, drowsiness, elation. Opioids can also lessen stress and discomfort by creating a much more relaxed detachment from their pain, from desires and activities. And those are some of the impacts or the effects that can lead to addiction. Opioids are also central nervous system depressants, and they can cause drowsiness, which is a common side effect of opioids. They slow our heart rate. They cause constipation due to their impact on our GI tract. They also cause slowed breathing and can cause respiratory issues among many people. I want to stress that opioids play a very important role in pain management, and we want to ensure that those who need opioids receive them and use them appropriately. And health literacy is really a key to appropriate opioid use. In the older adult population, about 30% have chronic pain from some of the things that Jennifer mentioned. Chronic back pain, could be pain as a result of a fall that are common among older adults, could be a result of surgery, fibromyalgia, headaches, all sorts of things. And pain, if left untreated, can really have a negative impact on all aspects of a person's life. We also see high rates of depression among people with chronic pain, and so we want to ensure that pain is appropriately screened, assessed, and treated, and that depression also is screened for and assessed among those with chronic pain. In addition, many older adults suffer from other chronic conditions, so many seniors are confronted not only with their pain, but dealing with trying to manage a variety of other conditions such as heart disease, hypertension, diabetes. So this slide provides a little bit more information on what we know about opioid use among Medicare Part D beneficiaries, which are primarily those over age 65. About 1 in 3 use or have been prescribed an opioid in the last year, and that's not surprising given the high rates of chronic pain among older adults, but they can also be prescribed for acute pain resulting from an injury or surgery. About 500,000 received high amounts of opioids, and that was defined as 120 milligrams of morphine equivalent dose over 3 months in this particular study. And that's taking about 12 tablets of Vicodin a day or 16 tablets of Percocet. So that's significantly high doses, and we see a large number of Medicare beneficiaries, which puts this population at high risk for addiction. Jennifer presented some of this data as well, but just to reiterate that we are seeing increases in prescription misuse among older adults. It's the second most common substance that's misused among seniors, alcohol being the first. But we see high rates of psychoactive medications being prescribed to older adults, such as benzodiazepines that are used to treat insomnia, anxiety, and sometimes depression. And we find that older women tend to misuse prescriptions at higher rates than older men who tend to use alcohol at higher rates. And these are some of the harms that can be caused by opioids for older adults. So we want to, educate older adults as much as possible about their use. We see higher rates of falls, motor vehicle accidents, side effects such as lethargy, that's the drowsiness, fatigue, decrease in respiration, high rates of suicide, elder abuse, and death. And this slide provides some detail on what we know about overdose deaths among the senior population. As you can see, from 1999, the rates have increased. For those who are misusing, we find that many of them are actually receiving opioids from friends or relatives for free, as this slide shows. So we need to think not only about those prescriptions that they're getting from their doctors, but they're also accessing them from family members or friends. So some of the factors that might be contributing to prescription drug misuse and abuse among the older adult population. I talked about multiple chronic conditions that many seniors suffer from. Because of these multiple chronic conditions, they see multiple prescribers. Oftentimes, the prescribers don't know what the other prescribers are giving their patients, so there can be a lot of confusion among older adults about their medications, and that can lead to misuse of those medications. We sometimes see multiple prescribers prescribing opioids to older adults, and sometimes that misuse of medications can lead to abuse. We also see some seniors, due to stressful life events and transitions that they're going through, such as bereavement, social isolation, that can lead to depression, self-treating their depression and other problems with psychoactive medications like opioids or benzodiazepines. So I wanted to just share with you a little bit about a wonderful tool that the Office of Disease Prevention and Health Promotion has developed. This is a great tool for healthcare systems to use for healthcare providers and others as a model to improve health literacy. And really the goal of this is to get patients more engaged in prevention, decision-making, and self-management. But there are a lot of things that systems and providers need to do themselves to engage patients as much as possible. And you can find this model, the health literate model, on health.gov with lots of great resources. But one of the key strategies around the health literate care model is around shared decision-making, and that is having effective dialogues with patients to ensure that healthcare providers really understand their patients' values and priorities around their care, that they understand maybe the types of medications they may have misunderstandings about or need more information about. And really this is so important for pain management. We want to involve patients in the development of a treatment plan as much as possible. The next is a teach-back method, ensuring that patients truly understand what the healthcare providers are saying to them, and that they can actually say the directions, for example, back to their healthcare provider. And patient engagement. Effectively engaging patients really reinforces their role as part of the healthcare team, and it can empower them to play an active role in their pain management. So these are just some of the ways in which we can improve health literacy among older adults and among caregivers who are caring for the older adults. And these are some talking points that CDC and others recommend to be discussed when someone is suffering from pain and are being prescribed opioids. It's important for people to understand that opioids really are most effective in reducing pain short term, and there is not a lot of evidence that shows that opioids can control pain effectively over the long term, yet we see a lot of long-term use of opioids. It's important for people to talk about non-opioid treatments, and I'll talk about that in a moment. Non-opioid treatments that can be as effective but with less harm. Also the importance of regular follow-up for providers to assess the effectiveness of pain management approaches, to discuss problems that people may be having with their pain management. Also, it's important to discuss safe storage of opioids, making sure that they're secure in a locked location, and how to safely dispose of unused opioids. And Jennifer talked a little bit about that, and I know some of the other speakers will describe some strategies. So those are some of the key talking points around opioid use. And it's important for patients to know about risks and side effects of opioid use, and that includes tolerance, that increased doses may be needed for pain relief over time, that physical dependence may result, and what does that actually mean? For some people, you may have symptoms if the medication is withdrawn when it's stopped, and that really tapering of the medication is really key, and how should opioids be tapered most effectively. Some older adults may have increased sensitivity to pain. They may experience the side effects I mentioned: constipation, nausea, vomiting, sleepiness, dizziness. Depression may actually result. As I mentioned, opioids are CNS depressants. Other information that patients should know about when they are prescribed opioids, they should understand that if they have a history of drug misuse or substance use disorder, that they're at higher risk for experiencing opioid misuse, that if they have mental health conditions such as depression or anxiety, they're also at greater risk. Some people develop sleep apnea when they're on opioids, or if they have sleep apnea, it could be made worse. And as we know, older adults are at higher risk for problems with opioids. Jennifer talked about alcohol use, and alcohol should be avoided when people are taking opioids. So having a physician should ask about opioid use and alcohol use when opioids are being prescribed. And also there are certain medications that should be avoided when opioids are prescribed, and I've listed those here. And Jennifer provided a great tool that I recommend people to use, and that is keep an up-to-date list of all the medications that you're taking and share that with all of the providers so that every provider knows what medications you're on, so that we can avoid problems like more than one prescription for an opioid, or contradicting medications like benzodiazepines and opioids. So what patients also need to know is, what non-opioid pain relievers are available, like nonsteroidal anti-inflammatories, Tylenol. There are other medications that can be used to treat pain. And these are some medications that are typically used for depression or seizure disorders, but they can be used to treat neuropathic pain. Also, physical activity is really important in reducing pain for many people, and there are certain types of physical activity that physical therapists can recommend. Also, cognitive behavioral therapy. People with chronic pain should also receive this, which is a it's a goal-directed approach in which patients learn how to modify their physical, behavioral, and emotional triggers of pain, their pain and stress. And it's also been shown to be effective for depression management. Additional information patients should know about opioids: never take opioids in greater amounts than prescribed. Follow up with your healthcare provider within a certain number of days, and the healthcare provider should provide that. There should be regular follow-up, as I've mentioned before. Work together to create a plan. Talk about ways to manage pain that doesn't involve prescription opioids, including some of the things that I just mentioned. Make sure the patient talks about any and all concerns that they might have and side effects. And it's important, too, to talk about ways to prevent misuse and abuse. And some of those ways are never selling or sharing prescription opioids and never using another person's prescription opioids. So this is kind of, practical information that people should have when they have chronic pain or other types of pain. And it's really good information to have a conversation with physicians. So these are some additional questions. Jennifer provided some excellent questions that everyone should ask about their opioids, but these are some others as well. Again, is it safe to take with other medications that I'm taking? Are there other non-opioid pain relievers? Is this the lowest dose possible? A rule of thumb in prescribing to older adults is always start low and go slow. And this is particularly important in prescribing opioids. Maybe they don't need as many pills as what is being prescribed. So a question is, may I have fewer pills? How do I taper the medication when I get to that point? And then we've talked about the importance of safe storage and disposal. So just very briefly, I wanted to mention some interventions that are appropriate when working with older adults and when you have concerns about prescription misuse or abuse, or also those who you work with who have chronic pain. So I've got a list of those here. I'll just go through them very briefly. SBIRT, screening, brief intervention, and referral to treatment. And for many, many years, SAMHSA has been funding states, tribal organizations, universities, medical residency programs, and many others to provide training on SBIRT and to implement it in communities across the country. So this is an intervention that's provided many different locations. So it's screening to quickly assess the severity of substance use, brief intervention focusing on increasing insight and awareness regarding substance use, and motivational interviewing towards behavior change around the substance use. And then if needed, referral to treatment for those who are abusing or addicted to substances. And this provides a little bit more information about what SBIRT is all about. But SAMHSA has many resources on SBIRT, and I encourage you to take a look at those. And SBIRT has been studied pretty extensively in the older adult population. Many studies have shown effectiveness of this approach with older adults in prevention of substance use disorders and identifying those who do have substance use disorders already and getting them into treatment. And one of the larger studies was known as the Florida Bright Project. And this slide provides some of those results of that project. But this study showed that it can be implemented not only in healthcare settings, but in community-based settings as well. The Chronic Disease Self-Management Education Program, there is one specifically designed for people with chronic pain, and that's being implemented more and more across the country. And this slide provides some details on what the program actually consists of. It's a 6-week session, 2.5 hours each session. It's highly interactive. Classes are very participatory. There's a lot of sharing, mutual support to build participants' confidence in their ability to manage their health, including pain conditions. And this is just an overview of the topics that are dealt with within the Chronic Disease Self-Management Education Program, and it does improve health literacy. There are components of the program that delve into working with healthcare professionals, medication management, questions to ask around medication management. So this is a really important intervention for those who do have chronic pain and other conditions. And then Healthy Ideas is a depression management program where I've mentioned we often see depression co-occurring with pain. So this is something, too, that some of you may want to look at to help people manage their their depression, and it's a community-based intervention. But it has also been shown to reduce self-reported pain. So we have information about all of these programs at ncoa.org, and I think I will leave it there and turn it over back to David. Thank you. We'll take questions at the end.
Well, thank you, Kathleen, for not only sharing such the depth of information, but for sharing that excellent guidance for improving patient-provider communication and offering rich examples of programs addressing substance abuse among older adults. Thank you. Now, our next presenter is Carol Levine, who directs the United Hospitals Funds, Families, and Healthcare Project. Now, this project focuses on developing partnerships between healthcare professionals and family caregivers, especially during transitions in healthcare settings. Now, before joining the fund in 1996, Carol directed the Citizens Commission on AIDS in New York City from 1987 to 1991, and the Orphan Project, which she founded from 1991 to 1996. Now, as a senior staff associate of the Hastings Center, she edited the Hastings Center report, and I hope I don't embarrass her by saying that she has been highlighted for her award-winning career, including receiving the MacArthur Foundation Fellowship for her work in AIDS policy and ethics in 1993, and for being named a WebMD Health Hero in 2007. So I am so very pleased to welcome Carol Levine.
Thank you, David. And no, I'm not embarrassed. That's lovely to hear. It all seems like it happened to another person, but okay. Well, I've learned so much from these presentations. I'm going to focus on the role of family caregivers in health literacy and pain management. And whoops, now I do this. Let me go back. The United Hospital Fund is a New York City organization. It's an independent nonprofit organization. We don't do direct services. We do public policy analysis and work with all kinds of providers and decision makers. My role has been in the Families Project, as David said, and we have a website that you can see on your screen, Next Step in Care, that has extensive resources for family caregivers. They're also useful for patients, of course, and they are guides to navigating the healthcare system, and they are in English, Spanish, Chinese, and Russian. So there's a lot of information. I think we should probably expand this to do something about opioids, but we have not taken that up specifically yet. The importance of health literacy has been very well described. I think I want to second all of the things that have been said, but to emphasize that healthcare today is complex and it's very challenging. As I was listening to all of the things that one should know about opioids, I thought, oh my gosh, I've been working on this for about a year now and I don't know all those things. So it's very challenging. And understanding multiple medications is essential, and particularly for older adults. And pain medications, as we've heard, present particular challenges. We were talking about prevention. I think a lot of people are worried about misuse, and a lot of the regulatory responses have been to control the improper prescriptions of opioids, but it's also important to recognize that many people really do need appropriate pain relief. There's a big difference between short-term use of opioids and chronic pain management. I think that's an important distinction. Prevalent misunderstandings and myths interfere with appropriate decision making, and I would say that stigma pervades our culture and includes healthcare settings. sorry to say. So health literacy, I would emphasize, it's hard to achieve. Even understanding basic health information and services is a high standard for patients and family caregivers, given the complex healthcare systems we have. People need to understand insurance, bureaucratic language, and institutional arrangements, not just medical terminology and what a prescription is ordering. So in my view, understanding services may be harder than understanding basic health information, which somehow we have a framework for understanding how the body works, how medications are supposed to act on our body. But services is just another world. So health literacy is particularly important for understanding drug treatment options, which are limited, especially in rural areas and even in some urban areas, as we know. So what the caregiver expects from the healthcare system is this kind of maze, that you go in at one point and you have to work your way through a system and meant to come out at the other end with the information and services you need. But this is what you actually get, and you can see the kind of lack of a clear path here. This is how caregiver feels in trying to be a good helper for an older adult who is experiencing pain or chronic condition. So family caregivers should be partners in care. It seems like a simple statement, and everyone says it, but not everyone does it. There are about 43 million Americans who are family caregivers, and that includes family members, friends, and neighbors, not just people who are related by blood or marriage. And they provide personal care, they do household tasks, and importantly, they undertake medical nursing tasks such as managing multiple medications, wound care, monitoring machines, picking up prescriptions, getting all the right routines in order. Caregivers, as I am learning, worry about pain medication a lot. They worry they're giving too much or too little, and it's a major source of caregiver stress. And it affects the relationship between the caregiver and the person who needs some help controlling pain. So caregivers are there. They accompany the patient to the doctor visits, ED visits, hospital stays, yet they may not be included regularly in medication reconciliation and decision making. And I'll say something about medication reconciliation in a moment. But they are often the ones who translate what the nurse or doctor has said in medical language to the patient, but they have to understand it before they can translate it. And if they're not part of the discussion, they don't understand it completely. At the same time, caregivers, especially if they live with the person, may have more accurate information about what a patient is actually taking or not taking than the patient, and maybe the patient may be unwilling to disclose exactly what they're taking for fear of being criticized or for fear that they won't get another prescription or for a number of reasons. So caregivers may get inconsistent and incomplete information from the healthcare system because they are not part of the decision-making process. But before learning new information, I think everyone has to unlearn misinformation, which is prevalent. And these are common myths that are in the culture. Taking pain drugs always leads to addiction. So you don't want to take anything. No drug is good. Or the alternative, if a doctor prescribed it, must be good for me. That was my mother's belief. A common one is, I don't have to keep track of my medications because they're all in the system. Well, they may or may not be in the system, especially if the different doctors that were alluded to earlier are not in the same system. So the drug information may be divided up among different providers and different systems. A very common, I would say, pervasive and pernicious almost myth is that medication-assisted treatment is just substituting one drug for another. There's a lot of misinformation about what a medication-assisted treatment is, and it's never just, should not be just another drug. It's a kind of drug routine, but supported by behavioral counseling and other kinds of support. So it's a comprehensive package, but it does include medications. And this is, the kind of judgment people who use illegal drugs, the fentanyls and the heroines, they're weak. They don't deserve costly treatment. Just let them die. You would be surprised, maybe not, but I was always surprised to hear what I would consider humane and caring people say these things like that. And finally, a very, very bad belief that treatment for substance abuse doesn't work. It's hard and it's challenging, but there are really a lot of stories and evidence that the right kind of treatment for the right person does work. So enhancing health literacy about pain medication, I think many of these points have been made, but I think it's good to reinforce them. Starting the discussions early, not while there's a crisis going on, and in considering all the medications that a person is on and whether some can be dropped, because people, especially as they get older and older and more prescriptions are prescribed, things get added, but they never get taken away. It's important to be just on the medications that are currently needed and currently providing benefit. Using simple definitions of types of drugs, how they differ, and this was mentioned earlier, it's very important. Explain how drugs affect the brain. That's something that we're not brought up to know about. Avoid demeaning and judgmental terms, and that's not just with patient but also with colleagues. I think there's some relearning that has to go on in some portions of the healthcare world. And remembering to dispel the myths that I mentioned, involving the family caregiver at every stage of the discussion and listening to their concerns that they're stressed and they're worried and they don't know what to do when the person is on presumably the correct dosage but complains about pain, or alternatively the pharmacist says, no, you've used up, I'm not prescribing this anymore, go away. All of those kinds of things are happening. So answering questions and repeating the information as simple way as possible is it's not just one time only. It's repeating and reinforcing. And teach back was mentioned to ensure comprehension. I work with a colleague I would call her the guru of teach back, and that's just a very simple in concept idea of not asking the person to repeat back what they heard from you, but in their own words telling the provider what it is that they're going to do. And you might be interested to know of it in some meetings that I've been going to lately. These are all on professional level. We do teach back in the meeting. Now, what is it that we just heard? What did we agree on? And it's really a very, very important technique to use. Medication reconciliation. Most people don't know the term, most patients and caregivers don't know the term med-rec, but they may hear it. So it's important that they understand what medication reconciliation is. And it's basically a process of creating the most accurate list possible of all the medications, including over-the-counter drugs and herbals that a patient is taking, and comparing that list to admission, transfer, discharge orders, or some other change with the goal of preventing adverse medical events. So while it's hospital-based for the most part, it can be used in an office setting if the patient has been in an ED or come and got new medications, and then it's a process of comparing everything that the person now thinks they should be on with what they really should be on, and that managing that process. So it's an important part of keeping the medications to the minimum needed, but also understanding the possible interactions. And medication management, which is a lot of what family caregivers do, is making sure that it's the right drug, the right dose, and at the right time. Here are some other points to be discussed with the patient and caregiver. I think most of these were mentioned. Why is the pain medication being prescribed? What are the benefits? What are the risks? Alternatives to the drug, non-drug alternatives. How long should I take the medication? I think that's very important for pain medication, particularly if it's been prescribed for, say, post-surgery or post-trauma, that this is not a medication you take forever. What are the side effects? And important, I want to stress this, how to keep the medication safe from children who live with me or visit. There have been many reports of children who find these drugs and unfortunately wind up in the emergency department. And how should I dispose of the leftover pills? I want to end with what a slide that lists from Rich Frankel in Indianapolis, the 4 habits approach to effective communication. And what's important about the title is that it's not just a technique, it's a habit. You get used to it, you do it, and you do it, and you do it, and then you do it automatically. It's a habit. Invest in the beginning, that is to develop trust between the patient, the provider, and the family caregiver, and elicit the patient's and family caregiver's perspective. The listening part is really essential. So often patients and families don't feel that their concerns are heard. Demonstrating empathy with words and body language. And finally, invest in the end. Summarize the conversation, review what next steps, so that the patient and family caregiver leave whatever the setting is with a sense of they heard what the provider said, the provider heard what they had to say, and everybody knows what to do next. If it becomes a habit, then it just becomes a way of communicating all the time, but it does take some practice if people are not used to it. So thank you very much, and I just want to mention when you get the written slides, you can download this article or this report that my colleague Suzanne Brundage and I did called The Ripple Effect, the Impact of the Opioid Epidemic on Children and Families, and it's available free online. Thank you.
Thank you, Carol. Thank you. Excellent information. Especially your points on the 4 habits approach to effective communication. The trust, listen, empathy, summarize and review. I think that's vital. Thank you for that, for offering us the much-needed caregiver perspective on this issue, because we know that involving caregivers and improving patient-provider communication is just imperative. So, we're down to our last speaker, Jane Marks. She is the Associate Director for the Johns Hopkins Geriatric Workforce Enhancement Program, which is a HRSA-funded grant integrating geriatrics into primary care practices and promoting community outreach. Jane has been a nurse in the Division of Geriatric Medicine for more than 30 years, working in primary care in a team approach with Dr. John Burton. And during this time, she has been involved with community churches, organizations, and outreach to promote healthy aging. So I want to give a hearty welcome to Jane.
Thank you, David. It's my pleasure to be here today, and I'm excited. We've heard some wonderful information about the opioid crisis and our older adults. And so what I'd like to address today is really talking about how we get that information out to our community and to our elders in the community. And as David said, I am supported through our Johns Hopkins Geriatric Workforce Enhancement Program, which is funded through HRSA, the Health Resource Service Administration. And we're under the Division of Geriatric Medicine here at Johns Hopkins, located on the Johns Hopkins Bayview Medical Center campus. So as I said, I'd like to discuss our community outreach and education through our faith-based communities regarding the opioid crisis today. We've had many partners, and I have to say I think one of the successes of our GWEP is the fact that we have had many engaged partners, not only here on the campus but in the community. But our partners in this initiative start with a church in Baltimore City, Brown Memorial Church. We also have partners on the Bayview Medical Center campus, and I'd like to just talk to you a little bit about their program and how they've impacted our outreach. So we work with the Healthy Community Partnership Team, which is a team here at Bayview that works with churches in the area. They have identified at least 6 or more churches in the community related to the hospital, as well as a little bit further outside the hospital community. And what they do is provide educational programs and promote health as well as caregiver education. I have the honor of being part of that outreach and work with one of the churches close by, and have found it very successful in having seniors identify with me and build a trust over time that they will ask me questions and guidance. We also have a very active community outreach department that has many connections in the community, and the director there is well known as well in many of our faith-based communities, so we're fortunate for that connection. We have an addiction medicine faculty that has been part of our GWEP and partnered with us over the years, and they often will help share their expertise not only in health professional meetings, but also they have been involved in many of our community outreach programs as well. In this initiative, we've reached out to the Baltimore City Health Department, and they were excited to partner with us in regards to their initiative in regards to the opioid crisis here in our city. I believe, as Kathleen talked about the Area Agency on Aging, one of our strong partners is our Living Well Center of Excellence, which is part of the AAA here in Maryland. And they have promoted many of the evidence-based programs. For those of you that aren't familiar with them, Kathleen gave an excellent overview. And I can only say they provide so much information to our community in regards to self-management and skills to integrate. And when you participate in those programs and see the results, it really is astounding. We're excited because part of our GWEP funding, we were able to provide leader training in the chronic pain program, which we had not had as many leaders as we liked across the state. So we were able to develop a training, actually 2 training sessions, and develop more leaders in chronic pain management. And lastly, we work closely with the Mental Health Association of Maryland. They've been a partner with our GWEP since the beginning, but also had interest in our initiative with the opioid crisis, so has participated with us as well. I'd like to just talk a little bit about Brown Memorial Church. So this is a church in Baltimore City, and they really set the foundation for our outreach on the opioid crisis because of their initiative of providing education. We met with them and the facilitator to better understand their program and gain their support to help extend that program to other faith-based communities within Baltimore City. They agreed to participate and help us with our outreach efforts, so we were excited about that. I'd like to just describe a little bit about what we're doing in the outreach to our faith-based communities. We actually approached 2 churches in Baltimore City who we've worked with in some of our other initiatives. They were excited to have us come and present information. We met with the church leaders, and they opened their arms to us, and so we modeled the program after Brown Memorial Church's program, which consisted of 2 sessions that included panels at each session to discuss various topics that you've already heard about and to answer questions on a one-to-one basis. We were lucky that the facilitator from Brown Memorial joined us and led our panel discussions. The first session that we held is really informal. We kind of had a little presentation, but really opened more to dialogue and discussion, which I think helped promote our trust and partnership. We did address addiction. We did address breaking the stigma that was addressed earlier in the discussion today. We talked about mental health and depression in regards to its role in opioid crisis. We talked about pain management, and much of what has been addressed this afternoon, talking about how they should be a partner with their healthcare team, addressing communications with their healthcare team, understanding what the prescription is that the doctor wants to give them, and then looking at alternatives, as we said, to pain management, and bringing up the possibility of alternatives, such as physical therapy or an exercise program, or looking at the chronic pain management program. And for those of you that aren't aware of the chronic pain, similar to what Kathleen described, it is a 6-week program, 15 hours of workshop, and it focuses on reframing pain and provides multiple strategies around managing pain. They gradually increase exercise as well as improve their communication skills about their pain. And we also provide to participants information about the chronic disease programs that Kathleen described. We also, in our discussion, included things in regards to medication management that was already addressed, maybe perhaps how to organize their medications in a pill box, the importance of knowing when to take it, how to take it, the strength, as well as making sure they understand when to stop and what they should be looking for. We address issues, as mentioned earlier, about storing medication safely, not sharing your medicines, how to dispose of unused medicines carefully, and then we also address the role of faith-based communities, how they can be the support to seniors as well as to help educate others and provide resource material. And it's important because we feel that this connection has allowed us to bring the information into the communities and disseminate it on their territory so that they're comfortable. These are some of the resources that we give out. We have handouts regarding the opioid use disorder. We have handouts on addiction. We give out information about properly disposing their medicines. We have a flyer on the National Take Back Day. We have a flyer that also lists police stations and pharmacies in their zip code area so they know exactly where to go in regards to where they can take back medicines. Our second session within the church deals with our 2 partners, the Baltimore City Health Department and our Mental Health Association of Maryland. The Baltimore City Health Department has a large initiative in addressing the opioid crisis. They also provide information on naloxone as well as administration, how to get it, and resources available for treatment within the area. And the Mental Health Association also addresses resources available as well as other information pertinent to mental health issues that are relevant to sometimes things that we see. Lastly, what I'd like to just share with you is that we've connected through Brown Memorial Church an artist, Peter Brune, who's known for his Beyond Beautiful 1000 Love Letter project. This is where he actually took love letters from a variety of sources and created drawings from parts of the letter. He's used his art in several ways regarding substance use disorder and mental health. One is a vehicle to end stigma and to promote healing, as well as he's used his art exhibit to break the silos and provide resource material to those that attend the art show. We are going to partner with Brown Memorial in having a workshop, a Road to Recovery love letter writing workshop. And although the letters may not necessarily be about addiction, it's about the power of love in our lives. And with his artist ability and as an activist, his goal is to help try to end the stigma associated with addiction. So we're excited about this adventure in bringing our churches together because Brown has opened their doors to our other church partners. And we're excited because we feel like our foundation has started out strong, and we will hope to continue this as we go forward with our GWEP activities and extend it to other church communities. So I'd like to thank you for your time and thank you for all the information that we've heard today and bringing about some solutions to what we've identified.
And we want to thank you, Jane, really for offering up real actionable examples of community outreach and educational strategies to address opioid misuse among this population. I want to, just before we get into the Q&A section, I want to reinforce a valuable resource that my colleague mentioned earlier in the presentation. I encourage everyone to use the SAMHSA Behavioral Health Treatment Locator, which you can find at the web address listed in this slide. If you are looking for answers to questions beyond finding treatment, we encourage you to talk to your healthcare provider. We aim to be a resource for you to address this issue, but we have limited time during our Q&A session, so that's why I wanted to just reinforce this particular resource. I also want to encourage you guys to download the Get Connected toolkit following today's presentation to learn more about linking older adults with resources on medication, alcohol, and of course, mental health. So we do have some time for a few questions from the audience. Because the presentation from all our presenters was so rich and so detailed within their presentation, they answered a lot of the questions that I saw in the chat pod, but I did want to pull out a few that I thought we could expound on just a little bit more. So I'm going to address about 5 questions to our panel that I think were hot button questions, and I'm going to start with this one. Can our speakers offer additional specific examples of how their organizations are partnering with the community? Jane, you want to start us off?
Well, so I think in regards to not just our faith-based communities, we've also reached out to 2 other groups of people. We do work in senior housing, which I find is very helpful. We do a lot of our chronic disease self-management programs there, and they're well received. So I feel that's an avenue that we can reach out to communities. These are seniors that are often limited in their ability to perhaps get out due to transportation issues, and so they welcome the programs. We've had a great success there. We've also partnered with senior centers that welcome us coming in and providing educational programs. not just only the chronic disease self-management programs that were addressed by Kathleen, but we also do other educational initiatives. So I see, between the faith-based community, senior housing, and senior centers, vehicles for us to get out there and reach our older adults.
Thank you.
David, this is Kathy Cameron from NCOA. Just adding to what has been said about this question, here at NCOA, we do work with a number of community-based organizations across the country. Certainly senior centers. We house the National Institute for Senior Centers. We work with area agencies on aging, faith-based organizations, senior housing. One of the areas that we're working on with them is definitely, the implementation of the programs that we've been talking about today, also how they can collaborate with healthcare providers in their community to address the broader needs of older adults who they're working with. There has to be that clinical community connection to holistically address the needs of seniors. And certainly pain management and opioid misuse and abuse is part of that. We need the two communities to come together. So that could be, ways in which programs are delivered at healthcare settings. For example, we're seeing more and more of that. Cross referrals of people into different programs across healthcare, community-based settings. And that's only going to grow as time goes on.
Thank you. I want to move on to another question that seems to be pretty popular, and this is for the full panel to chime in. How can we address the fact that some seniors may be shy or reluctant to be assertive and proactive with providers to partner on their care planning?
So I'm going to chime in, and then Kathleen, feel free, and anyone else. So
yeah.
I just want to share a story of a person I had in one of my chronic disease self-management program who was very shy, and after about the third class, then started to chat a little bit about some of her concerns. And certainly in that program, we teach communications and preparing for your physician visit. And I have to say, by the end of the program, she was so proud of herself. I think it empowered her with the skills needed to do that, in which she prepared for her visit. She talked to her doctor. She actually had some of her medications changed. She felt better. So I think if you're not familiar with the chronic disease self-management program, I would encourage you to look at that. I think it's a wonderful tool to help empower patients or seniors in the community to have that skill set, to feel a little bit more able to do that.
This is Carol. I think that a caregiver, a family caregiver, can help prepare the person for the visit by going over what are the things you really want to ask, what are the things you really want to tell, and get practice. Just say, let's pretend I'm the doctor and you're going to tell me what you want to hear. Because what happens is that you wait and wait and wait, and the thing that you really want to ask about, it's over before you get to that. So giving people, the sense that what's important to you got to come first, and practice doing that. That can help.
Also, David, it may not be that people are actually shy. It may be, different cultures and different levels of education may also play a role as to why someone may come across shy.
Good point.
Yep.
Thank you.
Yeah, and this is Kathy. I think also on the healthcare provider side, we need to give them tools and resources to have conversations and to ask probing questions when they're working with older adults about substance use and other issues too, when they are having difficult conversations with seniors and not getting information maybe that they need to make treatment decisions. So yeah, empowering providers as well with resources is important.
So I think I have one more time for one more question, and I'm going to direct this to my colleague. Will SAMHSA offer more events, trainings, and webinars focused on older adults? Jennifer,
yes.
I have some things in mind.
Yes. On May 20th, I had mentioned that there's Older Adults Mental Health Awareness Day. We also have had a series of webinars. Every time there's an opportunity, we have provided a series of webinars on older adults around opioid abuse. We're doing one today on medication misuse. We have really been working to really promote the Get Connected Toolkit again to make sure that, I want to say, using a loose term, new generations of people coming into the field or people who have just started working in the field know about the toolkit. We're working on slides on provider, how to use the toolkit from a provider lens, how to use the Get Connected Toolkit providers to consumer lens. So yes, and our sister center, the Center for Mental Health Services, also does a lot of work around serious mental illness. So yes, please stay tuned because there will be other opportunities that SAMHSA will promote work in older adults. This week, for the first time, we had seen from the Mental Health Technical Assistance Centers, they did a training on older adults.
So thank you, Jennifer, and thank everyone for your thought-provoking questions. A special thanks to our distinguished speakers. I hope that our time this afternoon has provided not only good information, but useful strategies for increasing health literacy and inspired action towards addressing opioid misuse among older adults. We hope that you will join us for our next webinar in April. We will discuss prevention workforce development. So please visit the MPW website at www.samhsa.gov/prevention-week to register today. You can also find past webinars archived on SAMHSA's YouTube page and the MPW website. So like I said, we hope that this information has been extremely valuable to you. Please tell us what you thought about this webinar by filling out the post-meeting survey that will pop up once this meeting ends, because your feedback is valuable to us and it really does help us plan future webinars. Thank you for your time, and we will see and hear you again very, very soon.
And again, ladies and gentlemen, this does conclude today's webinar. We thank you for your participation. Enjoy the rest of your